they actually go on YouTube to go catch up,
Okay,
or
perfect. Well,
anything happens, we don't want to lose this, so somebody will
yeah.
record. I'm getting that set up real quickly. There we go. They actually go on YouTube to go catch up,
Okay,
or
perfect. Okay,
okay,
so then,
we
uh,
said,
so, so with,
would you
go ahead.
introduce yourself or should I introduce you?
I'm happy to introduce myself. That's okay.
Please. Thank
Yeah.
you.
So, well, first of all, thank you very much for this invitation and the opportunity. I'm Alex Khalessi. I'm the chair of neurosurgery at UC San Diego and immediate past president of the Congress of Neurological Surgeons, which is our largest academic society in North American neurosurgery. And I was invited to give a neurosurgeon perspective on head and cranial trauma overall. And I think part of the spirit of the invitation is that there's really never been a more exciting time in the broad treatment of neurologic disease. And there's a real kind of fascination as we've moved away from just thinking about the brain in terms of structural terms, and in this era of computational science and materials that we're actually really starting to think about the function of the brain in new and different ways. And so that bears on any trauma patient from very mild traumatic brain injury to much more severe forms of injury that may require urgent to emergent medical attention. And given this is a diverse global medical audience, what I thought I'd do, and the reason these slides were selected, is kind of really highlight those situations where someone may be at risk of long-term disability or even death in the absence of kind of timely intervention, and how, as a neurosurgeon, we think about those things. And so, given that we have an hour together, I'll try to pace my comments for about 20 minutes. And so then that leaves plenty of time for kind of questions from the group. So a lot of the interest in and around head injury, when most folks in the lay audience kind of think about head injury, they think about a concussion that's received a lot of interest, obviously in sporting environments in terms of return to play guidelines for our children. And I think it's really helpful to make sure that we kind of deconstruct some of the jargon and just define terms. And so the term concussion really refers to a disruption in the function of the brain. And as our structural imaging has gotten better and better, an important distinguishing feature of concussions is the imaging looks normal. In other words, the structure of the brain looks intact, but there has been quite clearly the development of clinical symptoms by the patient, like issues with memory, focus, attention, visual disturbance, that really makes it clear that they've suffered an injury. And it's thought that part of what actually leads to that disruption of function is either the accumulation of fluid in the deep insulated tracts of the brain, or because our brains function by transmitting electrical impulses and chemical transduction with neurotransmitters, that if there's a dumping of neurotransmitter like glutamate in response to the trauma, then that leads to a temporary hangover and temporary interruption of the function of the brain. The best way to think about it, and the way I think about it, is if you think about your brain like a musical orchestra. What makes us us and allows us to experience the world is the music that's being played. And a concussion throws off the timing of the orchestra. So it's not like there's been a fundamental damage to the instruments, but people are playing either out of tune or not quite playing together and aren't quite synced. And it takes a little while for that syncing to take place again. And so, about 10% of injuries that take place in a sporting environment are head or spinal injuries. And we tend to actually grade concussions based on severity. And that's completely a clinical criteria. So it happens that I served as an unaffiliated neurotrauma consultant for the NFL for 6 years here in Southern California. And when we were actually developing those return to play guidelines, a big issue was trying to identify when someone could be cleared again for activity. And it was quite important that they were actually free of any symptoms before returning to rigorous physical activity, because it's thought that when you actually have ongoing symptoms from a concussion, there's a period of vulnerability where a second injury during that period of vulnerability would put the patient at significant risk for potential long-term neurologic consequences. In contradistinction or distinct from a concussion is a more significant injury called a contusion, which is a bruising of the brain itself. And you can actually see on the inset diagram, as you can imagine, the floor of the skull in which our brain sits is a very rough surface. And so when patients actually have an injury to their brain, it's quite common for the brain to move within the vault of the skull and to get this kind of classic pattern of bruising at the base of the frontal lobes and at the anterior part of the temporal lobes. The reason that's so important is when you think about how an injury to the brain pulls through to a deficit or a symptom that patients experience. The way I want you to think about it is there's a lot of redundancy between the left and right half of the brain. And the ones that actually cause a lot of symptoms are those where there's a symmetric injury. So people who have a symmetric injury to the same part of the brain, those people tend to have very significant clinical deficits. And so that's why this pattern of injury can be quite concerning. If you can imagine, if someone has a whiplash injury, like let's say in a motor vehicle accident, in addition to that initial injury frontally, there may be a rebound injury that takes place on the opposing vector of where that initial injury takes place. And so that's called a contra-coup injury, and what you can actually get with more severe forms of head trauma. The most severe form of head trauma, which is usually associated with high velocity injuries, is something that's called diffuse axonal injury. And the way that I want you to think about this is if you see someone who clinically doesn't look very good, so they're comatose, they're not able to be responsive to you in the way that you would hope after a head injury, but their scan looks relatively normal, meaning their CT scan looks relatively normal, that would be very concerning, because what I tell my patients all the time, and when we think about treatable problems in neurosurgery, the way that I want you to think about it is I'm hoping that when we treat that acute problem, that you'll have a target that will allow you to actually recover. But when you actually have a relatively normal scan in a severe or comatose patient, that implies that there's been a shearing injury in the very deep structures of the brain. And so I don't want to assume that everyone on the call knows how the brain is organized. And so the way I want you to think about the brain is you have the cortical mantle or the hemispheres of the brain that essentially make us and are responsible for initiating movement and how we actually experience the world. There are the deep diencephalic structures, which are around the fluid spaces in the middle of the brain. And so that can be the thalami, the basal ganglia. These are things that integrate information from the cortical mantle and from the cerebellum, which is in the back of the brain and actually is responsible for balance and coordination and complex motor learning. The diencephalon or the thalamus then communicates with the brain stem, which it communicates between the brain and the body and is the origin of the spinal cord. And so the way to think about it is everything that we think and do and feel essentially runs through the thalami and through the brainstem and communicating and sensing from our body. And so if those deep insulated tracts are injured, then it makes it very, very difficult in the long term to recover. And so I'm now going to transition, as I had promised, and talk about those sorts of injuries that, in the absence of medical treatment, are really concerning. And so, a good marker of force is if someone actually has a significant fracture, obviously, of their skull, because the skull is a very hard, flat bone. And so, it actually takes quite a bit to fracture your skull. And so, one of the things that we actually think about a lot is a situation like this where someone has a trauma and has a depressed skull fracture. So, in a situation like this, whenever there's either the drainage of spinal fluid or bony fragments that may be pressing on the brain and putting someone at risk for either weakness or a seizure, these are situations where these fractures need to be elevated and treated and the brain needs to be taken from an open system where there can be the leakage of spinal fluid and the introduction of an infection to a closed system. And so this would be a surgical lesion. And I already mentioned essentially the sort of symptoms that we would think about in that situation. And these are the criteria that as neurosurgeons that we actually use in order to actually decide is this operative or not. And again, what matters a lot is matching the finding or the structural injury or trauma to the patient's clinical exam. But if you're worried about an ongoing infection or a symptom that's referable to that part of the brain, that's obviously something that needs to be treated. The other thing is at the base of the skull, you're not able to examine the base of the skull. And so if someone has fractures in those locations, they often have indirect signs like a swelling of their eyes in response to that fracture at the base of their skull. And a lot of what we try to do in managing patients with head trauma is to actually manage their intracranial pressure. And a lot of that is driven by something that's called the Monroe-Kelly hypothesis, the idea that everything in the fixed volume of your skull needs to be either the brain, blood, or spinal fluid. And so if there's swelling or a mass lesion from bleeding in any one of these locations, then that's where we actually need to treat it. And then in terms of supporting someone through a head injury, a lot of what we do in supporting the heart, the lungs, and the kidneys in those patients is trying to make sure that we're looking at the mean arterial pressure and the intracranial pressure to maintain blood flow to the brain in this critical period. 15% of the time, someone with a head injury will have a delayed deterioration, meaning they'll suddenly get worse. And so that can be due to either global swelling of the brain, an expanding blood clot, hydrocephalus, which is essentially an expansion of the fluid spaces of the brain, or a secondary infection. And so these are the situations where we actually start to think about neurosurgery. And so this is just an example of someone who has dramatically dilated fluid spaces in their brain. And so we would pass a catheter through the substance of the brain to drain the spinal fluid to treat their hydrocephalus and save their life. This is an example of a skull fracture often can lead to a high pressure arterial bleed called an epidural hematoma. So these classically have a bilenticular appearance and they tend to not cross suture lines. And so this is a surgical emergency. This person has less than an hour to live. And so in these situations, though, if you take them out, they do very, very well. Because the source of the bleeding is not the brain itself, it's actually the skull. And the lower the epidural hematoma, the higher the risk, because what we're worried about is direct compression with the brain on the brain stem and an interruption of the connection between the brain and the body. A more serious type of hemorrhage is something called a subdural hematoma. So unlike an epidural hematoma, the source of bleeding here is usually a vein of the brain itself. You can see it usually covers the whole hemisphere of the brain. And the brain takes a double hit here because there's obviously direct mass effect on the brain, an irritation, but then there's also an interruption of venous outflow from the brain. So blood can flow to the brain, but it can't leave the brain. So the brain also swells. And so the hallmark of a subdural hematoma is shift, meaning midline shift, that's out of proportion to the thickness of the subdural. And so those are things that can be very, very concerning. And then lastly, you can have hemorrhages within the substance of the brain itself, or what are called intracerebral hemorrhages. In patients who have severe intracranial crises, you actually develop this reflex that's in response to brainstem compression. So that and a change in the symmetry of the pupils is very, very concerning. If someone has really high blood pressure, a really low heart rate, and is starting to have irregular breathing, they're at risk of what's called impending herniation or a fatal event from intracranial pressure in the head. Oh, sorry, the slide's not advancing. And then similarly, you can actually have shifts between the compartments of the brain, between the upper compartment of the skull and the lower compartment. And these are, in general terms, the situations in which we think about putting in an ICP monitor in our practice here. And so there's a 15-point scale that assesses the neurologic exam called the Glasgow Coma Scale. People who don't have a good exam that you can follow, meaning a GCS less than 8, we tend to put in a monitor and treat intracranial pressure that's greater than 20. And this is just an example of what those monitors look like that actually allow us to treat the pressure in the head. And so these are all the things, again, following the Monroe-Kelly hypothesis that we can do. So we obviously, if there's a blood clot, you want to evacuate that blood clot. If there's spinal fluid, you can drain it. And obviously, you want to manage and protect the substance of the brain by driving the sodium and elevating the head and using these kinds of medications. Obviously, in patients where there is a mass lesion, there's a variety of surgical approaches that we can use. It's quite uncommon now in our practice in modern neurosurgery to use barbiturates, but we do sometimes do a decompressive craniectomy to allow the brain time to swell. And then I'd mentioned in terms of a Glasgow Coma scale, it's a 15-point scale that's based on eye opening, the motor exam as assessed by the arms, and if the patient's able to talk or not. If they are not able to talk or they're intubated or have a breathing tube, they get a T score for that. And so overall, in this very kind of brief overview, what I hope I've actually done is kind of showed you the spectrum of head trauma from a very mild concussion, which is an interruption of the function of the brain. And I hope in the discussion period, we can kind of talk through how we think about concussion and some exciting new science in that area. Then moving into progressively more serious head injury and the sort of things that are treatable or maybe life-threatening to a patient because of a violation of the cranial vault and causing an infection or spinal fluid leak, or if there's a blood clot or swelling or a mass lesion that as a surgeon we need to think about evacuating. I know that was a lot of information in a very compressed period of time, but wanted to kind of introduce each one of those topics and then obviously invite a broader conversation. We can do a deep dive on any one or all of those subjects if it's helpful. So with that, I hope that's what folks had in mind, and I'm happy to open it up to questions.
Thank you so much. That was deep, quick. Yes, a lot of information, but comprehensive. Thank you so much. So now we take questions. People can raise their hands for questions or put it in the chat box so I can read them out to you to answer. But I have a question.
Yeah,
So,
please.
for, you know, traumatic, when we talk about brain injury, would you talked about concussion in that midst. We've seen a lot of
Hmm.
research on concussion that there is sequela
Hmm.
to and that it's dangerous, especially in athletes. We've been seeing that. Can you
Hmm.
comment on that and what to look for if, say, somebody gets hit, they have a concussion? Um, what should one do? How should one follow that? And how can one abate negative sequela?
Yeah, so there are a couple components to that assessment. One is in the moment, meaning immediately after the trauma. How do we actually think about the different classes of symptoms in terms of progressive risk to the patient? So the first is obviously most folks who experience a concussion tend to actually, you want to first assess, was there a loss of consciousness at the time of the trauma or not? So that's actually quite important. And do they have are they amnestic to the event or do they remember the event? And how long were they out for? And was it a witnessed mechanism? In other words, were they alone and they actually took a fall, or they were actually in playing a sporting event and had an unprotected fall and a head-on-head collision? So those are kind of the early screening questions. Then once you actually have made that assessment, then you actually look at kind of three classes of symptoms. One is kind of headache and constitutional symptoms. So if they're having, persistent headaches and nausea to the point of vomiting or vision changes, that's kind of the first kind of class of symptoms. The second class of symptoms are kind of executive function symptoms, and these tend to linger the longest, meaning issues with memory or executive function, the ability to kind of follow multi-step commands. And there's lots of screening guidelines around that. And then the third and most serious is if anyone has a fixed neurologic deficit. So meaning like weakness or numbness of their arms and legs, slurring of their speech. Anyone who has a fixed neurologic deficit, they're already kind of out of the concussion category, and that person's going to need some imaging, because you want to remember that 26% of the time patients do actually have, in addition to a head injury, have a neck injury. So sometimes they will need imaging of their head and their neck if they're in that fixed neurologic deficit category. So that's typically the acute assessment, and people are using a range of validated, often iPad or written checklist questionnaires to run through those symptoms to kind of categorize that concussion as mild, moderate, or severe. And then the next step is after that acute concussion assessment. And some folks I should mention also are using things like pupillometers, meaning looking in the back of the eye at the pupillary light reflex to actually assess a lag in the pupillary reflex is thought to be a sign of a more severe concussion. There's some early science around that. And then after that initial assessment, then it's really a time of kind of cognitive rest and rehab. So limiting exposure to light, loud sounds until someone is completely symptom free. And only when they're completely symptom free do you then gradually escalate their activity and allow them to return to play. As I mentioned in my comments, if someone has ongoing symptoms and they suffer a second injury, it's thought that that can actually be much more serious and long lasting because they've now sustained a trauma during a period of vulnerability. So when you look at then, the only acquired form of dementia is chronic traumatic encephalopathy, or CTE, which has gained a lot of interest in professional athletes. A lot of what put people at risk at CTE, it is the fact that they had that repetitive head injury while they had symptoms. And so that's been an important kind of first step in professional sporting environments to actually walk that back. So hopefully that's a good kind of first step in terms of how to think about concussion.
Thank you. So I have some hand raised, but I think this is a follow-up question to mine. I wanted to ask it quickly. It says, does the length of time to heal depend on the age of the victim? And
Yes.
one, yeah.
Yeah, so absolutely. As you get older, you're less resilient and more inclined to have poorer cortical plasticity. The other practical issue is that as we get older, our brains lose volume, and so the gap between the volume in the skull and the volume of the brain gets greater, and so it's more likely with a comparable a trauma, there'd be a greater injury or a higher risk of that particular type of blood clot called a subdural hematoma. In terms of overall healing and recovery, because I saw that question in the chat, that healing is largely a function of the period of rest and recovery that's given after that initial trauma. So again, avoiding that second hit is the first step. And then as a second step, a good kind of rule of thumb is you need to give yourself double the time you had symptoms in order to actually ultimately recover. So if you had, lingering symptoms from a concussion from, let's say, a week, you should expect a full 2 weeks after that. So really at the 3 week mark before you should really feel that you are back to kind of having recovered your overall functional baseline, your pre-trauma baseline.
Thank you so much. Auntie Tawa, kindly unmute and ask your question.
Good evening, everyone.
Good evening. Welcome, ma'am.
Dr. Khalessi. I'm sorry if I messed your name.
No, that's okay.
This question is about it's much more of a PD. There's some PD with a cerebral palsy, and they have like a ventricular drainage that drain from their skull back into their peritoneum.
Mm-hmm.
Is there a possibility that they can pull that out, or they're going to live like that forever?
Yeah, no, I appreciate that question. This is something that commonly comes up. For children that are shunted at birth, they are typically thought to be shunt dependent, meaning there's not really a safe way to remove that long term. And part of the reason that is if you think about the physiology of spinal fluid generation and absorption, in general, our brains make and absorb about 400 cc of the spinal fluid a day. And once you actually shunt someone, in order to maintain the right buoyancy of their brain and spinal cord within their body, they have a very revved up mechanism of spinal fluid production. So they compensate for the shunting by making much more spinal fluid. And so it's quite rare to be able to successfully wean that shunt because they're overproducers of spinal fluid. For those CP babies or CP children, a common that a question that commonly comes up in neurosurgery is when do you actually have to externalize that shunt? And we've become more permissive in that way. And so, in general, it now requires really gross abdominal contamination. So, a ruptured appendix, a bowel perforation, a rupture of their gallbladder, kind of a clear infection where you're worried about an ascending contamination of the spinal fluid. But in the absence of that, it's quite rare that someone who is shunted at birth, and it's typically not just for CP, it's for IVH of prematurity or spina bifida or a Chiari malformation. Those folks tend to be shunt dependent long term.
Thank you.
Thank you. Dr. Jagbe, kindly unmute.
Hey, Dr. Khalessi, thank you so much for the robust presentation. I have three questions, but
Sure.
the first one I want to ask is the long-term motor affectation of people with head injury. How does it present?
Well, so it depends a little bit on the severity of the injury and what's involved. So in general, I kind of outlined in terms of kind of the structure of the brain. A lot of your recovery is a function of which part of the motor apparatus was initially injured. And so folks, for example, with an injury to the kind of the planning or motor association part of the cortex tend to have what's called a neglect or an apraxia. So they'll have challenges with kind of complex motor movements, but may actually have reasonable strength when you actually test individual motor groups. So they may be able to grip, but they actually don't necessarily have good functional strength in terms of, let's say, picking up a soda can. People with a primary motor cortex or a thalamic injury, those folks actually tend to have the most flaccid form of paralysis that you may see. And in patients who are actually paralyzed, there's kind of this kind of move it or lose it component to their recovery, where if they're completely paralyzed, the challenges and concerns are different because our muscle is really reliant on kind of tonic ongoing communication from the nervous system. So you'll start to see atrophy in those situations. You can see contractures or spasticity develop. So a lot of the medical treatment for those patients actually tends to be supportive because you're actually trying to prevent those negative things from happening because of the paralysis. And obviously the limb that's affected will dictate kind of what those symptoms ultimately look like. And so a lot of the work and probably one of the most exciting areas of research is in the area of kind of neuromodulation. So those patients who actually don't have a complete injury, meaning they're not totally paralyzed, but they're clearly weak. And there's a lot of work that's being done in the development of either closed loop stimulation or the delivery of like a biologic to try to enhance recovery in those patients. And so depending on whether the initial injury was a trauma or a stroke or a hemorrhage, or for example, a sharp or penetrating injury to the spinal cord or the peripheral nerves, a lot of the recovery in those situations is a function of the initial injury and how much function's left. And if you have a little bit of function left, you can really actually kind of fan that flame in a way that you couldn't, 5 or 10 years ago, and get to a much better functional outcome.
Thank you. The second question has to do with the cranial nerves.
Mm-hmm.
Knowing that the cranial nerves come out from the base of the skull, from the base of the brain,
Mm-hmm.
how do they present really? For clinical observation?
Yeah, if you look, it depends again a little bit on the scenario. So maybe it would probably be most helpful is to maybe just walk through the cranial nerves and tell you kind of the clinical situations where I pay attention to one more than the other. So, for example, in that situation where we were worried about an anterior skull base problem. So, for example, that patient who actually had a bruising of their frontal lobes, or patients who actually have a tumor of their anterior skull base, like let's say what we call an olfactory groove meningioma or a pituitary tumor. Those patients often first present with a loss of the sense of smell because our olfactory nerve or cranial nerve 1 is 1,000 hair-like chemoreceptors that go through tiny little perforations in the base of our skull. That's called the cribriform plate. So smell or loss of smell is a very sensitive test for patients who actually have anterior cranial base pathology. Optic nerve or cranial nerve 2 is obviously responsible for our vision. And so a lot of the way as neurosurgeons, we use the visual exam is to actually assess the optic apparatus. The key thing to distinguish between an ocular problem or a problem with the eye or a problem with the brain is problems with the brain don't get better when you close one eye. And so if a patient can close an eye and whatever visual disturbance they have goes away, then it's probably not necessarily a problem with the brain. The exception to that is an issue with cranial nerves 3, 4, or 6, which are responsible for the eye movements of and the conjugation of the eye movements. And so, if the eyes are not moving together or not at midline at baseline, if a patient has bad double vision looking in one direction, that implies a problem with one of those cranial nerves. Um, Cranial nerve 5, which is sensation of the face, or the trigeminal nerve, that tends to actually be a unique component of the exam that isn't really relevant to most of folks outside of neurosurgery. But some people can develop pain syndromes of the trigeminal nerve that are called trigeminal neuralgia. And so that's the main way where a fifth cranial nerve exam matters. And then 7 and 8, the facial function and hearing. Patients who have unilateral hearing loss that's painless. That there you do need some imaging to rule out potentially a mass. Facial function is really important in basilar skull fractures. So if someone had a severe head trauma and had spinal fluid coming out of their ear, and you'd want to check their facial function for where the facial nerve actually crosses the petrous bone. And then we don't really assess a cranial nerve 10 or the vagus, but 9, 11, and 12, so the tongue, the spinal accessory, and your swallowing function, your glossopharyngeal nerve, are all things that are assessed commonly in looking at strokes of the brainstem or high spinal cord injury. I should also mention that swallowing dysfunction is kind of the most common thing that's missed, and that's exactly why particularly in patients who have a breathing tube, it's really important to do a cough and gag assessment and what we call a cuff test, meaning you let down the cuff around the breathing tube to make sure the patient's moving air around the breathing tube before you take it out. Because in someone who's had a breathing tube, if you don't do those things and then take it out, it's much more likely they'll vomit into their lungs and have an aspiration event of their lungs that can be quite serious. And so those lower cranial nerves, I have to say, are probably the most important in someone who's been a great save, and you want to make sure that you have that person's able to protect their airway well, and it's often those lower cranial nerves that are responsible for making sure that happens.
Yeah, you mentioned something about Bell's palsy.
Yeah.
How does it last? I mean, how long does it last? And what could be done to alleviate Bell's palsy?
Yeah, so Bell's palsy, just for the benefit of the group, is a spontaneous weakness of the face. It tends to actually be graded on a 6-point scale called the House-Brackman scale. It's thought to be a reactivation of a virus in the nucleus of cranial nerve 7. Cosmetically, it's actually quite disruptive to the patient's life because they actually have a full drop of their face. And unlike something, so the initial, oops, sorry, I lost the sensor light in my office. The initial The initial assessment should be, can the patient raise their eyebrows? Can they blow out their cheeks and hold a seal? And can they smile? And if all parts of the face are involved, you can grade the degree of weakness from 1 to 3, and then the key branch point in the 6-point scale is a House-Brackman grade 4, and that's if the patient can't close their eye. So the most important thing in a Bell's palsy case is, can the patient close their eye, particularly when they're asleep. So a lot of patients who can close their eye when they're awake, when they go to sleep, you need to have someone watch them sleep and make sure their eye is completely closing. If it's not completely closing, that person needs a moisture chamber at night, or needs drops and artificial tears, or needs their eye taped at night. And the reason that's so important is because if you lose your tear film and develop an exposure keratitis, that can threaten your vision. So you can develop corneal ulcers and bad problems. So the only medical consequence of a Bell's palsy is a potential threat to vision if you aren't able to close your eye. If you are able to close your eye, then unfortunately we don't actually have a lot in terms of kind of supportive therapy to shorten the course. But in general, you should expect the prognosis overall is excellent, and you should expect a recovery in the 3 to 6 month time frame.
Thank you. So the last question I want to ask is about shaken baby syndrome.
Sure.
Do you see a lot of that here in the West, or is that something that is common in the tropical area?
No, it's unfortunately all too common elsewhere. We have a kind of a blanket term for that that's called non-accidental trauma, and so there's a few things that we look for. The most diagnostic are retinal hemorrhages on fundoscopic exam. That's quite classic. The other thing that we look for are obviously any evidence of other trauma, particularly long bone fractures of differing ages, or if you actually see distinct lesions in different parts of the brain. So any one of those things are things that kind of trigger a kind of a broader kind of social assessment of the child's environment, and whether, unfortunately, non-accidental trauma may be responsible.
Thank you. Excellent.
Thank you so much. And when the eyes don't close, we recommend that you use like the eye covers and all of that,
Yeah.
so you don't dry out. Yeah. Thank you so much. Man, Dr. Jagbe, you asked a lot of important questions. Thank you. Dr. Zugu, kindly unmute. Thank you.
Yeah, thanks again, Khalessi, for your presentation. That was excellent. Couple of questions from me, from my end is, one, can you comment on the role of robotics really in these traumatic brain injury things? And can a patient who have no mental problem that has a traumatic injury to the brain, can they develop other mental issues subsequent to that, even after they've recovered? And last but not the least, has to do with a physiologist who keep having recurrent subdural hematomas, small here and there, small here and there, issue with balance and then resolves. But he likes chopping wood with axe as his exercise. And he doesn't believe that that has anything to do with this recurring subdural hematomas, and we can't really figure out any reason else why this is happening.
Mhm.
Okay. So I'll take those in order. In terms of the role for surgical robotics, I'd say right now, in general terms, for cranial surgery, robotics are used more for a deep brain stimulation or stereotactic EEG or laser ablation in kind of tumors or epilepsy, or in stereotaxy for biopsies, more than in trauma. The main role in trauma would be if you needed to pick a trajectory to a deeper lesion in the brain, like a deeper blood clot in the brain, which tends to be associated more with vascular problems like AVMs or aneurysms. or high blood pressure than it would be in a true trauma situation. There's a lot of surgical robotics used in the placement of spinal instrumentation for spine trauma. So that's an area where there's a lot of surgical robotic adoption currently in kind of the broader treatment of a spine patient. Pivoting to your second question, well, maybe I'll take the subdural patient first, and then we'll kind of circle back to your second question. Oh yeah, your second question was actually about other delayed symptoms in patients who actually had a head injury. The reality is that if you look at actually the progression of symptoms from concussion, it tends to be, headache, as I mentioned, headache, nausea, vomiting, visual disturbance. The second kind of class of symptoms, which can be delayed, are issues of, like I said, executive function or mood or affective symptoms. So someone who's suddenly irritable or disinhibited, or maybe not acting like themselves, that absolutely can be a delayed sequelae of a head injury. And then in patients who've had repetitive head injuries, the last kind of stage of symptoms or class of symptoms, they begin to develop executive function disturbance, ability to attend to complex tasks, dementia. There's a lot that actually is kind of wrapped up there. So I would put the progression into kind of those three stages. So if the spirit of your question is, can you develop, delayed mood disturbance from a head injury? The answer is yes. And then the third case that you presented, the reality is that someone who's had recurrent subdurals, it may be the kind of the Valsalva or the wood chopping, meaning that the sudden bearing down. But the reality is that once you've had a subdural hematoma, the way that your body responds to that is by trying to wall off the fluid collection. And we used to think that these were really static collections, meaning once you had a clot around your brain, that until that absorbs over time, nothing really changes. We now know that that's actually not true. What happens in response to the subdural is your brain tries to actually wall that off with fibroblasts. And so membranes grow from the lining around the brain or the dura to try to encase the subdural. And those membranes actually develop leaky blood vessels in them through a process called neovascularization. And so as opposed to being a static collection, there's this very dynamic process where the membranes leak fluid into the subdural, and that's what leads to the persistent recurrence. And so we helped actually here pioneer a treatment using catheters to embolize or take the blood supply to those membranes, and then the subdurals would disappear. And there was actually a phase 1 clinical trial in which I was on the steering committee for, called Embolize, and there's now been a second trial that demonstrate the durable benefit of MMA embolization for subdural hematomas. And so I would bet more than his activity that if we looked at his scans, he probably has membrane formation, and that's the source of the recurrence. And then obviously there's also either due to medications or someone who's has a clotting disorder. There's obviously a set of labs we would also send in that situation to make sure there's not a hematologic abnormality that's responsible for the spontaneous subdurals.
No, I appreciate that very much. Yeah. Yeah, from a lay perspective, we'll think more of just the trauma of Valsalva and stuff, but your deeper explanation, could explain what the recurrence, and thanks for that information. Great.
Thank you. And thank you for always educating us on the heart, Dr. Izugo. That's a cardiac. So, Tina, kindly unmute.
Thank you. Good evening.
Good evening.
I just have a follow-up. Thank you for the opportunity. I just have a follow-up question real quick. I have a list of questions in the chat as well, but I quickly wanted to follow up on the last question. So did you say that as far as progression, I hope I heard that right because I'm not in the medical field, that people with brain injury survivors, there's a possibility for them to probably develop other things in the long run as they grow older? That was one of my questions, that probably maybe over time as they heal, does that mean we need to start looking out, probably if we have a victim, to look out for probably other things that might develop?
Yeah.
aside of
So yeah,
okay.
no, I understand the spirit of the question. So as all of us, as all of us look at kind of the natural history of the aging brain over time, our function tends to actually have kind of periods of plateau. And so someone who's had a history of trauma can excuse me, absolutely have more exaggerated plateaus. And so that's why I tried to highlight that there's kind of three kind of classes of symptoms that we look at, right? So one class is an increase in the frequency and intensity of structural headaches or nausea or vision changes. A second is disturbance of mood or irritability. And then the third is a disturbance of kind of executive function or dementia. And absolutely having a strong history of head trauma can unfortunately accelerate that risk of dementia that all of us have. And so trauma definitely can make that worse. To speak to your questions in the chat around the ability to dream, um, by intent or not, you're actually touching on a really important subject, which is that one of the fundamental things that change as we age is the architecture of our sleep. And so, if you think about what's actually involved in the biology of sleep, and if you believe that everything that happens in our body is for a reason, it's kind of an odd thing that we developed in a way that for a third of the time we would be unconscious and vulnerable. Like that's a huge biological cost to pay. And so it stands to reason that the reason you pay that cost is the advantage or the benefit of high quality sleep is even greater than that period of survival disadvantage of being vulnerable while you sleep. And when we look at the ability to dream or not, a lot of it is a function of your stages of sleep. And dreaming is exclusively associated with the REM stage of sleep. And that's actually something that tends to happen a little bit later in the night in kind of the early morning hours, and is essentially the last stage of sleep after you've successfully progressed through the other stages. And so, if for whatever reason, because of organic brain disease, or environmental factors, you're not progressing through those stages, you're actually not going to be able to recall or constructively dream. And that's a lot of the time when we actually consolidate our memories and learning as well. And so there's a lot of interest right now in the architecture of sleep and dreaming, and how it actually relates to overall brain health. So that's what I would say is the likely significant of dreams in the case that you mentioned.
And seems like it's not something that might probably happen at some point, maybe not, because
Well, I can't.
everything you mentioned, she's actually going through everything from, of course, the executive function that you mentioned, the vision, and that's why I asked that how probably does it depend on age and how long it takes them to recover, because all those things, short-term memory, everything's still like there. So, and
Yeah.
that's
So
right.
yeah,
And
yeah. So, well, it's hard for me to responsibly comment without seeing the specifics of her scans, but just when you think about the system, if you wanted to kind of look into it further, that subserves dreams and memory is the limbic system. So it'd be the hippocampi and the temporal lobes. And then there's a circuit involving the fornix and the base of the frontal lobes, that is basically around those deep fluid spaces of the brain, and the ongoing communication in that circuit is really what's responsible for all of those functions. And so she has an injury, like I said, a symmetric injury in that same location on both sides. That's when it's more likely that her symptoms are going to be long lasting.
mhm. Okay. All right. Yeah, at least that's one of the things I wanted to get more, I guess, information about, and you pretty much just explained it. And I believe there's probably one quick question. Did you say that as far as probably the eyes not closing, did you say that I don't know if I heard you clearly. You said something about 3 to 6 months for that to
Yeah. So typically, someone
okay.
who has a weakness of their face from a Bell's palsy, meaning there's not another diagnosis that would explain the weakness of the face, like a stroke or a mass. If it's truly a Bell's palsy, which is a diagnosis of what we call exclusion, meaning you've taken those other structural causes off the table, then those people tend to recover in 3 to 6 months. And they just need to have their eye protected during that period until they develop facial recovery.
What if it's as a result of the brain injury in terms
Yeah,
of
so if they have a weak face, it depends on the part of that. It kind of speaks to our earlier conversation around motor recovery. So if it's an injury to the hemisphere or what we call the cortical mantle, then those tend to have a better prognosis. If it involves the brain stem or the facial nucleus, or the thalamus, those folks tend to have a longer term injury. So meaning that can last a year or more, or potentially be permanent.
all right, that was what I needed to clarification on. Oh, okay. And one last, I'm sorry, I don't want to take the old time. One last thing though, the symptoms that you talked about in terms, not symptoms, I guess, more of things to look out for. So over time, as they probably heal, and this is just from experience, what would you suggest that we do for, so I'm just going to give you a quick example because I don't know how to explain. After a couple of years, she just started to feel like she couldn't get to the bathroom enough to actually pee, or to get to the bathroom early enough to pee. And that was not part of what was the issues she had before. And then getting out of bed and trying to, it seems like it seems like she can't feel that she wants to pee until it's too late. And that's
Yeah.
not been a problem. So what do you intend?
Yeah.
I mean, what are the suggestions of what we can do in that
Yeah.
process?
So the way that I think about incontinence more broadly is between involuntary or what's called urge incontinence. And so it sounds like she senses it, but isn't kind of making it in time. And so in those situations, in general terms, it's not necessarily an issue of the brain unless there's actually an interruption in the spinal fluid circulation of the brain. So there's a condition called normal pressure hydrocephalus that can lead to that kind of incontinence. When you have urge incontinence, like what you're describing, where someone feels like they have to go to the bathroom, but they don't quite make it, it often can be due to pelvic floor dysfunction, particularly in postpartum women or women who've had babies, or it can be an issue of spinal compression at the level of the lumbar spine and disruption of the sacral nerve roots. And so it's really hard for me to responsibly comment with a little bit more information and some imaging, but that would be in general terms how I would kind of classify incontinence and the sort of workup that would be done to kind of categorize that further. And I know we're getting close to time. I do unfortunately have a 5 o'clock local stop, so maybe we'll grab maybe one last question.
Yes,
Thank
Dr. Ajagbe, kindly unmute.
Yeah, thank you again. I just wanted to raise an issue. It may not concern a lot of people, but have you seen patients with low force fractures that actually affect the brain in such a way that we have leakages through the nose,
Yes.
the CSF, even through the back of the throat that we can talk about?
Yeah, that's very common actually, and actually very important to identify because as I had mentioned earlier, that's concerning in terms of someone's long-term brain function for a few reasons. One is there's a risk of life-threatening meningitis because I want you to think about spinal fluid like rocket fuel. It's designed to optimize the biological environment for the brain, so bacteria love spinal fluid. So they'll always ascend up a CSF leak in the back of the throat. So often that repair, if it's not involving an endoscopic ENT surgeon who can turn like a vascularized nasal flap, there are times where we have to fix that from above. In other words, you do a craniotomy and do a pericranial flap on the base of the skull to stop that leak. After you actually do the surgical repair, you put in a lumbar drain, usually for a period of 48 hours to 5 days to protect that repair and actually allow it to seal. Occasionally, you need to actually shunt those patients if they have a persistent leak after that. But someone who has a CSF leak in the setting of facial fractures absolutely needs a neurosurgeon because that's life-threatening.
Yeah, thank you.
Fantastic. Thank you so very much. I know you have this next meeting, and I will want to just thank you from the bottom of our hearts for impacting into us. This is a very important subject, and it's a brain um, brain injury awareness month. So
Yeah,
thank you for
well,
doing this for us.
I really appreciate the invitation and the engagement and all of you for building the global community you have to advance health for everyone. So thanks very much for the opportunity to be a part of it.
Thank you very much. God bless you. Have
All
a
right,
blessed
take care,
day.
guys.
Thank you.
Okay, bye-bye.
Bye-bye.
Thank you.
So I just want to say and remind us that on this forum, we don't establish patient or physician-patient interaction, but we do engage in answering questions, giving information, and brain is a very important organ in our body. Every organ is important. The brain is very important. And I'm glad that we're able to, get a neurosurgeon to come talk to us about brain injury in order to create awareness this month. I also want to thank Tina for bringing it to my attention that it's Brain Injury Awareness Month and that we need to, really talk about this. So next week, we'll actually bring people who have been impacted with traumatic brain injury to come share experiences and we can learn. The brain is very important, and I'm very surprised that we didn't have a big turnout tonight because I know people are thinking, oh, I don't have anything wrong with my brain. I don't have to come, but hey, wrong. I believe that we have learned a lot tonight, and I hope that we can help people around us who may have had, traumatic brain injury or, who know somebody or who are dealing with it in helping others, that we can help them too from what we have learned. So thank you so much for participating tonight. And till we meet next week, please let's stay safe. If we don't have any other questions that we can answer,